Hi, it's Jocelyn Compton again, presenting another section of the respiratory chapter. Let's shift our discussion now to talk about respiratory pathology. The first topic in respiratory pathology is in the upper respiratory system, the sinuses. Rhinosinusitis is likely a familiar condition for you. Here, there's an obstruction of sinus drainage into the nasal cavity. The patient will feel all stuffed up because they're exactly that. Take a look at this image. Here you can see the maxillary sinus is filled with fluid. Where's the most common site of sinus inflammation? The maxillary sinuses. Do you remember from anatomy why that is? The drainage orifice of the maxillary sinus is superiorly placed, near the roof, impeding drainage. What is the most likely cause? A viral URI. However, once a patient has a viral infection, a superimposed bacterial infection can also occur. What are the most common bugs? Strep pneumo, H. influenzae, and M. catarrhalis. Knowing these bugs for this condition will make you look like a rock star on your pediatrics rotation. Deep venous thrombosis, affectionately referred to as DVT, is very high yield because it's the primary cause of pulmonary emboli, which we'll talk about next. Here you see a picture of a DVT that has caused swelling and redness. So, do you remember Virchow triad from the hematology talks? Sure you do. Patients are predisposed to the development of DVT on the basis of venous stasis, hypercoagulability, and endothelial damage. In other words, you are getting inappropriate activation of the coagulation cascade. So what types of case presentations on the boards will make you think of DVT? Well, classically, you think about orthopedic trauma patients, or really any patient who is immobilized for a period of time. Other folks at risk include older patients, women who are pregnant or postpartum, people who are taking long plane trips or car trips, cancer patients, and women on birth control pills. Do you recall from the musculoskeletal section which autoimmune disease can also result in hypercoagulability? Lupus, the great imitator. Holman's sign is tenderness of the calf muscle with passive stretch, such as dorsiflexion of the foot, and can be an indication of DVT. However, Holman's sign is usually not very sensitive or specific. So you should usually try to make the diagnosis with duplex ultrasound of the extremity in question. How would you treat a DVT? Patients with DVT are commonly treated with heparin, low molecular weight heparin, and warfarin to keep the clot from expanding and greatly reduces the chance of pulmonary embolus. This venogram is from a 15-year-old girl taking oral contraceptives whose left leg became severely swollen after a long airplane ride. As you can see, there is complete obstruction of the left proximal femoral vein, propagating into the distal IVC with multiple dilated collateral vessels. Name 3 major contributors to DVT formation. Venous stasis, hypercoagulability, and endothelial damage. Virchow triad. The topic of pulmonary emboli is a classic boards and ward topic. You will talk about this all the time as a third-year student with any patient who has sudden onset of dyspnea, chest pain, and shortness of breath. Sometimes it can present only with tachycardia, so if you're in the ER, always have PE in your mind. There are a number of things that can embolize to the lung arterial vasculature, and that's pretty much summarized here by the fat-bat mnemonic. Fat, air, and thrombus, bacteria, amniotic fluid, and tumor all may comprise pulmonary emboli. Fat emboli classically occur with long bone fractures and liposuction. These patients have hypoxemia, neurologic abnormalities, and a petechial rash. This is an H&E stain of a blood vessel in the lung. The patient died of a massive fat embolism after an ERCP that resulted in pancreatitis. If a woman presents just after delivering a baby with a stroke and shortness of breath, what should you be thinking? Amniotic fluid emboli, which in addition to PE can also lead to stroke an anaphylactoid reaction, and also DIC. What is DIC again? Disseminated intravascular coagulation is widespread activation of the clotting cascade, leading to bleeding, bruising, and kidney failure. The classic tip-off on the board's question is oozing IV sites. This peripheral blood smear shows peripheral blood schistocytes and helmet cells in a patient with DIC. That being said, most pulmonary emboli arise from deep vein thromboses in the legs. You should know that although most DVTs occur in the calf, these don't always embolize. The most common site of embolization to the lungs is from the femoral vein. This patient has a DVT in which vein? The iliac vein. That's correct. Here is a PE that came from a femoral DVT in a 60-year-old male who presented with sudden death. This is a massive saddle embolus blocking the pulmonary artery, so you can see why this was a fatal event. You can also see that the clot was formed sometime prior to death, when you look on the stain. Here you see lines of Zahn, where you have pale layers of platelets mixed with fibrin alternating with darker layers that contain red blood cells. The first step in diagnosing a pulmonary embolus involves a high degree of suspicion. In the ER, you will usually not see too much with a chest x-ray or an ECG. So a CT pulmonary angiography for visualizing the pulmonary vasculature is the test of choice. Where is the most common site of origin for pulmonary emboli? The femoral vein, even though the most common site of DVT is the calf. So here's another huge topic for the boards, and it's a big group of diseases in general. How big, you ask? COPD alone kills more than 125,000 Americans each year. To understand obstructive lung disease, it's important to understand forced vital capacity, FVC, and forced expiratory volume in 1 second, FEV1. FVC is measured by spirometry and is the volume of air that can be forcibly exhaled in one full expiration. The patient is asked to inhale as much as possible and then exhale as much as possible. FEV1 is measured in a similar way, but is only the volume of air that can be exhaled in the first second. In a normal person, how much air should they be able to force out of their lungs in 1 second? About 75 to 80% of the total lung volume. By definition, obstructive lung disease involves obstruction of airflow with air trapping in the lungs. During exhalation, the airways close prematurely at higher lung volumes than normal, thus resulting in increased residual volumes and decreased forced vital capacity, since less air is able to leave the lungs. Think for a moment about the diagram of lung volumes that we went over in lung physiology, and think about how obstructive lung disease would affect lung volumes. Pause the video for a second if you need to. We'll talk about this a little later on when we compare obstructive lung disease with restrictive lung disease. So as you can see, FEV1 decreases as well. Less air is exhaled from the first second of forced expiration. Since FEV1 decreases to a greater extent than FVC, the ratio of FEV1 to FVC drops, which is a hallmark of obstructive lung disease. Since these patients also have decreased ventilation due to a lower vital capacity, they have decreased ventilation and increased perfusion, or a VQ mismatch. So now let's discuss COPD, asthma, and other forms of obstructive lung disease. Patients with chronic bronchitis can be thought of as blue bloaters. This is one of the common types of COPD. What's the underlying pathology? The pathology of their disease involves hypertrophy of mucus-secreting glands in the bronchioles, which can be quantified with a Reed index greater than 50%. What is the Reed index? The Reed index is a ratio of the thickness of the gland layer to the total bronchial wall thickness. The mucus and inflammation causes the obstruction, which causes the body to decrease ventilation and increase cardiac output, creating that VQ mismatch. You may also see secondary polycythemia as the body attempts to compensate for poor oxygenation. How will you know a blue bloater? These patients classically present with a chronic cough for greater than 3 consecutive months per year for at least 2 years. They also have wheezing, crackles, cyanosis from shunting, and dyspnea on exam. You might also see signs of right heart failure, which gives them a swollen, bloated look. Let's do a flash quiz. What happens to FEV1 in obstructive lung disease? It is decreased. When you think of emphysema and also chronic bronchitis, what is the very first thing that should come to your mind? Tobacco smoke. How could the patient be described on general exam? Barrel-chested, breathing through pursed lips. So, with smoking, you get this characteristic destruction of airways in the terminal bronchioles, classically called centroacinar, before spreading peripherally. This leads to decreased recoil and increased compliance in the lung, and it presents with dyspnea, decreased breath sounds, tachycardia, early onset dyspnea, but late onset hypoxemia, and eventually wasting. The pink puffer look comes from the effort to puff through pursed lips and increase airway pressure to prevent airway collapse during exhalation. Other morphologic types of emphysema are panacinar, caused by the alpha-1 antitrypsin deficiency, which is very board testable. Normally, what does alpha-1 antitrypsin do? Well, it inhibits neutrophil elastase from breaking down elastin. So no alpha-1 antitrypsin means more breakdown of elastin in the lungs, which leads to panacinar emphysema. Alpha-1 antitrypsin deficiency also causes liver cirrhosis, where the typical patient is younger and not a smoker. When should you think of alpha-1 antitrypsin deficiency? A young patient with liver and lung problems or unexplained emphysema with liver enzyme abnormalities. That being said, a patient with alpha-1 antitrypsin deficiency should still avoid smoking because it can worsen the panacinar emphysema. Here's a picture of a patient's bronchiole who has asthma. Note the mucoid exudates in the lumen, the goblet cell metaplasia, and the epithelial basement membrane thickening. So how is asthma different from COPD? Asthma is classically caused by bronchial hyperresponsiveness, leading to reversible bronchoconstriction, whereas in COPD, the obstruction tends to be fixed. Now remember, there's a spectrum of disease where you can have a bit of overlap between the two conditions. The classic pathology associated with this asthma is smooth muscle hypertrophy, airway inflammation, and mucus plugging. Kirschmann spirals are shed epithelium that is a byproduct of the mucus plugging. You can see the obvious corkscrew shape here. So, if you looked at the sputum of an asthma patient, what else could you see? Well, you might find Crayola bodies, charcoal Leyden crystals, and of course eosinophils, especially in allergic asthma. What do eosinophils do in asthma? Eosinophils release major basic protein, which causes epithelial cell damage and bronchospasm in asthma. In allergic asthma, you will also see Th2 cytokines, like IL-4, IL-5, IL-10, and IL-13. If you don't know which cytokines drive allergic inflammation, go back to the immunology section for a quick review. The findings of an asthma exacerbation are cough, especially at night, wheezing, dyspnea, and tachypnea. How would you diagnose asthma? With a methacholine challenge, which is addressed in the pharmacology section. Finally, we come to bronchiectasis, which is a permanent, irreversible dilation of the proximal and medium-sized bronchi. This condition may present with purulent sputum, recurrent infections, and hemoptysis. Causes of bronchiectasis include necrotizing infections with bugs like staph and Klebsiella, as well as bronchial obstruction, poor ciliary motility, Cardigan syndrome, cystic fibrosis, and allergic bronchopulmonary aspergillosis. Here you see a chest x-ray of a cystic fibrosis patient with bronchiectasis, scarring, and mucoid impaction. Note that he has relative sparing of the left lower lobe. This is a coronal CT in a patient with recurrent and chronic pneumonia. You can clearly see the dilated bronchi, especially on the right side. Let's do a flash quiz. What does alpha-1 antitrypsin inhibit? The answer is elastase in the lung.